Welcome to the IPQ Academy, and in particular to our series that helps nurses improve the knowledge on areas affecting their training and their everyday clinical practice. Today's talk concerns ascending aortic aneurysms, and it's a part of our thoracic aortic disease series. The main teaching points of this presentation is the aortic anatomy, aortic pathology, specific reference to ascending aortic aneurysms, and an overview of the treatment for ascending aortic aneurysms. The literature on the diseases of the aorta is vast. For the purpose of this presentation, I would recommend our audience to familiarize themselves with guidelines on the treatment of aortic disease, and more specifically, the American guidelines published in 2022 and the European guidelines published in 2024. The heart is located behind the lower half of the sternum, with the edges of the heart both being visible on an X-ray on the right and left aspect of the sternum, and in particular between the fourth and fifth rib, where the apex of the heart is the closest. On the right picture, the heart has been removed, and the shape and course of the aorta is visible. The aorta starts just above the aortic valve, ascends behind the upper part of the sternum, arches backwards towards the spine, and descends almost parallel to the spine before it bifurcates into the iliac arteries. The aorta, being the largest artery of the body and receiving practically all of the cardiac output, supplies various organs through its branches, starting with the coronary arteries supplying the heart, the great branches of the arch supplying mainly the head and neck, before it descends into the thorax with its intercostal arteries supplying the spine and the thoracic wall, before it enters the abdomen with branches to the intestine, kidneys, muscles, before its bifurcation into the two iliac arteries. For the purpose of unifying the terminology of the clinical anatomy of the aorta, it has been divided into various segments, starting with the aortic root, which is the segment between the aortic valve and the sinotubular junction, zone 0, which is the ascending aorta above the sinotubular junction, before the aorta arches backwards into zone 1, between the innominate artery and the left carotid artery, zone 2, between the left carotid artery and the left subclavian artery. The aorta then enters zone 3, which is the first part of the descending aorta. Under the microscope, the aortic wall consists of three distinct layers. These are, from the inside to the outside, the intima of the aorta, which is covered by the endothelium, the media, which consists mainly of smooth muscle cells and elastic fibers, and the adventitia. This is the outer layer of the aortic wall, which is mainly responsible for the strength of the organ. The main types of aortic pathology are aortic aneurysms, with which this talk is mainly concerned, acute aortic syndrome, which includes aortic dissection and rupture, intramural hematoma, and the penetrating aortic ulcer, and also the subject of aortic trauma. The abnormal excessive enlargement in the diameter of a segment of the aorta is called aortic aneurysms. Ascending aortic aneurysms are common. They're usually asymptomatic. And the main reason that concerns us clinically and often require treatment is the fact that they are often associated with regurgitation of the aortic valve and also the risk of aortic dissection, which increases significantly once the size of the aorta has exceeded a certain diameter. The limits of the normal aortic size have been defined by previous aortic disease guidelines. More specifically, these are 40 millimeters for men and 34 millimeters for women. It is known that the aorta naturally grows in diameter as we age. An acceptable growth for men is up to 0.9 millimeters per decade. This is 0.7 millimeters for women. Individuals with connective tissue disorders display a significantly faster increase in the diameter of the aorta. Connective tissue syndromes are some of the commonest causes of aortic dilatation and often aortic dissection. The commonest conditions of connective tissue disorders affecting the aorta and other arteries are Marfan syndrome, which mainly affects the strength of fibrillin. More specifically, well over 1,000 different genes have been identified causing the condition. Loeys-Dietz syndrome affects the strength of the collagen, which occurs through mutations of the transforming growth factor. Ehlers-Danlos syndrome is also a disease of the collagen and has been recently divided with 13 different types, with the vascular and the cardiac type of Ehlers-Danlos syndrome being the most relevant for a cardiac clinician. An important dilemma: clinicians treating patients with aneurysm of the ascending aorta is the question of whether an aneurysm needs treatment and at what stage. Indications for surgery have been defined by previous guidelines. An aorta that has grown to 55 millimeters in diameter should be considered for surgical correction. This cutoff point was reduced recently to 50 millimeters in aortic centers with sufficiently low rates of morbidity and mortality. Patients with Marfan syndrome should be treated once their aorta has reached a diameter of 50 millimeters, whereby patients with Marfan syndrome and other risk factors such as family history of aortic dissection or a rapid increase in the diameter of the aorta to over 3 millimeters per year should be treated at a lower size of the aorta. There is lack of clarity and data with regards to the surgical treatment of patients with Loeys-Dietz syndrome and Ehlers-Danlos. It's widely accepted that these are lower than in patients with Marfan's or non-connective tissue disorder. Similarly, patients with Tarman's or otherwise X0 phenotype should be treated once the aorta has exceeded 27.5 millimeters per square meter body surface. Bicuspid aortic valves are associated with dilatation of the ascending aorta. It is widely accepted, though, that there is no difference in the cutoff point concerning the indications for surgery in patients with bicuspid aortic valve. A patient who requires cardiac surgery for a non-aortic reason, such as coronary disease or vascular disease, should undergo concomitant replacement of the ascending aorta if this exceeds 45 millimeters in diameter. Multiple clinical conditions may be the cause of dilatation of the aorta. The commonest etiology is hypertension and atherosclerosis, followed by connective tissue disorders, as discussed in previous slides. As also discussed, there is an association between a bicuspid aortic valve and aneurysms of the ascending aorta. Inflammatory conditions and infections, such as giant cell arteritis or syphilis, also cause aneurysm of the ascending aorta. A traumatic injury of the aorta can be followed by a development of an aneurysm which is often calcified. From a histopathological point of view, atherosclerosis results in the formation of intima lesions of the aorta. Aneurysms and dissections are usually the result of medial degeneration, and inflammatory conditions and infections tend to affect mainly the outer layer or adventitia. In recent decades, a considerable amount of work has been carried out trying to identify indications for surgical correction of the ascending aorta. We know from work carried out by Lefteriadis and colleagues at Yale University that once the diameter of the aorta approaches 6 centimeters, the risk of complications increases significantly. This literature is one of the reasons the European and American guidelines recommend surgical correction of the aorta once its diameter has exceeded 55 millimeters. This picture, taken from the most recent European guidelines for the treatment of aortic diseases, shows the various shapes dilatation of the aortic root and ascending aorta can take. The aortic root is often the sole segment of the aorta that displays abnormal dilatation, but this can also be associated with the dilatation of the ascending aorta or zone 0. There can be isolated dilatation of the ascending aorta when the root remains of normal size, and there can also be dilatation of the ascending aorta entering the aortic arch. Ascending aortic aneurysms can be treated in a variety of ways and with a variety of surgical techniques, depending on the factors such as the involvement of the aortic valve, the size of the root, and the extent of the aneurysm as it approaches the aortic arch. An aortic dilatation can be treated with complete replacement of the ascending aorta and aortic root with techniques such as the Bentel procedure or the use of a homograft or the Ross procedure. The aortic valve can sometimes be spared while the aortic root and ascending aorta are replaced, Furthermore, the ascending aorta sometimes can be replaced above the coronary arteries. There may be replacement of the ascending aorta with separate replacement of the aortic valve, or a technique developed more recently which involves supporting the aortic root in ascending aorta with an external layer of artificial material, also known as the Pearce procedure. The surgical techniques for treatment of the ascending aorta and its aneurysms will be discussed in more detail in another training video offered by IPQ Nursing. For the link, please visit our website on www.ipqnursing.co.uk. Thank you for listening.